now than ever before.
This meeting is being recorded.
Got it. Let's see. Sorry about that. All these little buzzers are going off on my computer. Yes. So would you like to get started? I don't know if there's going to be more people trickling in as we're going.
I think we could start. Yeah.
Okay. All right. Very good. So I'm not sure if they gave you the presentation for you guys all to look at. I know they were going to put it on the website. So if not, I could always email it to you individually or as a group. So I could give you my email address and you could always let me know. And I will be more than happy to do that for you after the presentation.
Probably best to email me, Stu Gilman.
Okay. All right. What is your email?
swgillam@yahoo.com.
Okay.
Gillim.
swgillim at
Yahoo.com.
Yahoo. Perfect. All right.
then,
I will do that.
And then I can get it on the website if it isn't already there.
Okay. Yes. Check that out. It was supposed to be. So I want to talk to you about geriatric care management and how important it is to have an outside advocate aside from family, friends, a social worker at the hospital. Has anyone heard of geriatric care management, or has anyone ever used a geriatric care manager in the past?
We're in the process of finding one.
Okay. Okay. Very good. So let me tell you a little.
And you and I know each other. I'm Pat Smith.
Oh, hey, Pat, how are you?
Good. Yes. So I know what it's about.
Yes. Great. Nice to hear your voice again.
Yep. Thank you.
Yeah. So just a little bit about my background. I have been a nurse for 30 years. I started Seniors Choice Care Management about 15 years ago. And the reason I started it was 15 years ago, my mother was at 64 years old and she was showing signs of dementia. And I couldn't believe at 64, she could have dementia. This type of work was foreign to me at the time. Yes, I was a nurse, but I didn't specialize in this type of nursing. So when she started to get forgetful, I was just, of course, very concerned. I went away for a week. I came back. It was unbelievably advanced in that last week, to the point that I called the doctor. We brought her into the emergency room, and she was diagnosed, it wasn't dementia, she was diagnosed with 5 glioblastoma brain tumors and given 3 months to live. Our world, of course, right? Your world is upside down. It's a crisis situation. Who helps you? How to navigate through everything? What are the options? At the same time, my elderly grandfather, 91 years old, was, of course, worried and scared and had a stroke a couple days after I told him what was happening to his daughter. So I had my dad, or my grandfather and my mother at Strong Memorial Hospital, 5 rooms apart, both very ill and not sure how to navigate through it all. It was very scary. The social workers truly didn't help us. They helped us very superficially, but they didn't tell me why. Why wasn't rehab covered? Why wasn't this medication covered? Why does my grandfather have to do this type of hospice and not the type that we're hoping for? So there were so many things that no one really could answer those questions. And it was really, really scary for all of us. And my sister's a nurse, I'm a nurse, my brother's a physical therapist, and we thought we knew it all, and we didn't. And so before my mom died, she said, you should help people, help them navigate through this, help them figure it out, because it's not working for us. So I worked, she passed away 3 months later, and I worked for another year as a nurse on an orthopedic floor, and I had her in my little background in my mind saying what I should be doing. So I had 2 little kids at home, and I quit my job and I started this business, Seniors Choice Geriatric Care Management. And I learned from the ground up. I researched, it was crazy times, but it worked, because 15 years later, here I am. I have a staff of nurse care managers. very, very blessed. Every family member, patient we have, resident we have are just like our own family. And it's a heartfelt business. Care management is wonderful. So I highly recommend taking a look at my website, other websites of geriatric care managers, and just learning a little bit more about that. And that's where I think this presentation is important. It's going to educate you guys on what is it and how does it work, and is it appropriate for you currently and maybe in the future. Geriatric care management, it's basically the project manager of someone's care. So as you want to be a caretaker, or maybe you're the patient yourself, and you want someone to kind of guide you through it, to educate you what's out there, to advocate for you, that's what we do. So just on the presentation that will be online, what I wrote on here was geriatric care management is designed to assist families with understanding, planning, and managing the care of a loved one to improve their quality of life and maintain their independence. Geriatric care managers have extensive knowledge about cost, quality, and availability of services in the community. Most importantly, we determine the level of care a patient needs and consult with families regarding the different living options that are out there in the community. So it could be as in-depth as helping with placement and educating you on the different living options. It could be helping someone get out of the hospital and into rehab, or out of rehab and back home. So we could be as involved as much or as little as you want. So each case is different. And please, I'm going to keep this presentation open to questions as we go along. Yes, we'll ask some questions at the end, but if you have that question in your mind that you want addressed right away, please feel free to interrupt, and be more than happy to answer that for you. So in the senior community, and I'm sure you guys are aware of it, there's different levels of care. And the different levels of care start off at, of course, your home, or you could be doing independent living in a senior community, for an example, like Ferris Hills. That's independent living. From independent living goes assisted living. And then there's an assisted living for memory care assisted living. And then there's a fairly new level of care, and it's called enhanced care. Not every assisted living has the licensure for enhanced care. It's a little step below a nursing home. So when we want to try to keep patients out of nursing homes, we always try to say, well, are they a candidate for this enhanced care? And there's certain criteria medically that they have to meet, financially that they have to meet. The next level of care is a nursing home, and a nursing home has hospice care as well. You could also do hospice in your home with the appropriate resources. The independent living is just that. You live by yourself in your apartment, but they have some certain amenities. Transportation, they have some transportation usually. They have your meals, maybe 2 meals a day. They have a little bit of house cleaning, a little bit of laundry. So it's a little bit of more support than just your basic home, your residential home, and that's independent living. People live at independent living for years and years, and we help them hire aides, caregivers to come into their home or into their apartment if, for an example, they're at Ferris Hills. We have probably 3-4 patients now at Ferris Hills that either need memory care assisted living or a nursing home, and we're able to maintain them safely in their apartment there. So as long as you have the resources and a backup person, because caregivers call in sick, and then we have to be careful for that. Any questions about independent living or anything pertaining to that right now before we go on to assisted living?
Do
Nope.
people who are just having independent living in a facility, do they have a requirement that you have what they call a a caregiver? In other words, can you, what is the word? Say a loved one who lives in the same house or not?
Oh, so if they live, if you're living in an independent living facility, can your family member be part of that caregiving, or do they have to hire someone?
Right,
Is that
right.
either one? They're not, as long as the patient, their resident, is safe. So for an example, we have a lady or had a lady that was living independent living, and her daughter said she was helping take care of her. Well, she was, but not enough that it made the independent living community comfortable enough by keeping that resident there. So they pretty much insisted, you could live here, but you need to hire someone else but your daughter because you're not getting the care you need. So as long as you have care and you're safe, no matter who it's with, usually they're okay with that. Sometimes those independent living places do like you to have a care manager on board, because then they know there's that extra support, extra backup in case there is a crisis.
Would you please spell Ferris Hill? Is it with an A, F-A-R-R-I-S, or is
F-E,
it with an E?
yeah, Ferris is F-E-R-R-I-S, Ferris Hill,
Thank you.
H-I-L-L-S. You're welcome.
They,
Yep.
they have, they also have assisted living. I think one of the things we really have to make distinct here is independent versus assisted living, because there's a line where you cross there, where your care changes.
Absolutely.
My
Yes.
daughter works at Ashton Place.
Okay, yep.
And so I'm very familiar, and I'm a pharmacist. So
Okay.
I'm very familiar
Very
with this distinction.
Yes, independent living is just as the name says, you're independent. Assisted living is that next level. So just say you're living in independent living and you might need some more help, but you're thinking, geez, I really can't find caregivers to come in. I can't find quality workers. So I need to move to an assisted living. And then that next, like Mike was saying, the next level of care is assisted living. In assisted living, they're going to help you with all your medications. There's a nurse there. Ferris Hills, yes, does have assisted living. It's called Clark Meadows. And they have aides there. So if you need a little help with bathing, they're there to help you with bathing. They'll help you there with your medications. They help with transportation. Most assisted livings have their own doctor. If you wanted to treat with their in-house doctor, you could do that. You don't have to. It is kind of nice just to walk down the hall and your doctor's right there if you need to see him or her. They help you with toileting, bathing, dressing. They have all your meals prepared for you, transportation, medication management, and the physician in the community. So it is definitely a nice little turnkey, so you're not scrambling and independent living trying to find the help. Some people aren't ready quite yet for assisted living, and then that's where trying to hire a little bit of help coming in until you may possibly need to move to that higher level of care.
At which point in your care continuum or your health continuum, if you're in, say, a level 1 on assisted living, I know there are some places who are residences who end up having to ask the person to leave because he either can't get out of bed. They're not licensed to give high level care or 4th level care. Isn't that true?
You're right. Yes, Judy. So you could live in assisted living for a certain amount of time, but as your care needs increase, they may say, you need to now move to the next level of care. And usually what determines that is if a patient needs physical help getting out of bed, if they need that extra little oomph from an aide, or they need a Hoyer lift, or they need some type of a lift, or if their incontinence is just out of control and the toileting schedule just isn't working. There's a couple different things that could play into that. eating. So just say a patient, either one can't physically get food to their mouth, or if their dementia progresses and they sit in front of their food and they really need a lot of encouragement and prompting to eat, then that would encourage that assisted living to say, you better get an assessment because I think you're probably going to need a nursing home. When assisted livings or even families aren't sure what level of care their loved one or their resident is at, they'll ask us to do an assessment. It's called a PRI, a patient review instrument. And a patient review instrument in New York State only, of course, it is mandatory to get this assessment for placement into a nursing home. So some people, even though you know mom or dad or husband and wife aren't ready for a nursing home, sometimes one, it's nice to get a PRI to get a baseline. Sometimes it's nice to get a PRI to say, how close are they maybe to that next level of care? And for sure, for a nursing home, you have to have one. It's mandatory. So some of the assisted livings will say you should get a PRI then, not knowing if they should stay living at assisted living or if they need a higher level of care. Which is the reason why the assisted livings now are trying to get their extra license for the enhanced level of care. An enhanced level of care is a little bit more hands-on help. So most assisted livings would discharge a patient somewhere else, and now they're trying to hold on to. I'm sorry?
I was saying that I I had unmuted my iPad to a person who's with me. But I was wondering, what if normally a couple is pretty independent, but then one of the couple, the caregiver, wants to go away? Can you bring someone in to substitute for her?
Yeah, so that's called respite. So respite, you could either one, hire, depending on how resources is, it's not as easy as it sounds, but depending on different home care agencies, you could either one, hire aides to come in, and that would be more than likely probably 24/7 care. And then what we do is some of our patients that have home care and the caregiver goes out of town, we always make our visit that week or that 2 weeks while the caregiver's gone to make sure everything looks good, the patient's okay, the caregivers are showing up. That's a little hard because if the caregivers call in sick, there needs to be a backup, and that needs usually to be family. So if the caregiver's sick, there's the family that has to step in while the caretaker is out of town. Or you could do a respite at an assisted living, or you could do a respite at a nursing home. So usually with those respite, we're not sure which level of care that patient would need, what level. Each assisted living and each nursing home has a little different criteria. They're 10 days, or it might be 10 to 14 days. And the way healthcare is now, it changes so frequently that if that was something that was that you wanted to look into, you really do need to call that assisted living, or we need to call that assisted living or that nursing home to see. And if that's the case, then to go into the nursing home, you would have to have that PRI for respite, that patient review instrument assessment for respite in a nursing home. So there's definitely, it's doable. It just takes some time, lots of paperwork. Yeah.
Thank you very much.
You're welcome. You're welcome. So that's why assisted living places are trying to get that extra enhanced care licensure, because they want to hold on to their patients a little bit more. And when you have that enhanced care level of care, they're able to physically touch that patient and help them out of bed, help them stand from a seated position, help them in the bathroom a little bit more. Sometimes help them with oxygen or insulin. The enhanced licensure in New York State is a huge umbrella, and out of this umbrella come all these little fingers, and off those fingers are different license, oxygen, insulin, and some assisted livings might have oxygen, Hoyer lift, and one person assist, whereas the other one may not want that. So again, just because one person says or one place has enhanced care, it may not mirror the same as the other one. So you have to really be careful with that as well. Not a lot of people know that. Mhm.
Once somebody's in assisted care, do they have a care manager usually?
So in assisted living, there is a nurse and there's a social worker or a care manager. So there is someone there in-house managing things a little bit to a certain degree. If you want to be very specific, look at other options, a little bit more hand-holding, that's where hiring an independent private care manager is different. So a lot of those care managers in assisted living actually refer out or refer to us for when patients need that higher level of care, or when patients just aren't managing that well at their level, they'll actually refer it out for extra help.
Yeah, that at Ashton, they have both levels.
Yeah.
And you need to have somebody who can realize the necessity for the change in level. And so they need to have somebody on staff that can do that. But when they do, bringing in a private care manager is very often what you see.
Yeah.
But a lot of times, assisted living people end up skipping the enhanced and have to move on past that. It's
Right.
all an individual progression thing.
It is. And what people don't know, and I had a lady, and it's a really sad situation. And this is where I think care management is important, even like a one-time consultation to look at all options, because what happens in enhanced care, they don't take, once you drain your money there, like if you run out of assets in a nursing home, they'll put you on Medicaid. If you drain your assets in enhanced care, they don't take Medicaid at all, and you'll get kicked out. So you have to be very careful. I had a lady that she had long-term care insurance, and and that's all she had, a little bit of assets, but mainly long-term care insurance. And the facility was great. They took her in, and we got called and said, she needs to leave here. She doesn't have any more money to pay her care. And so when I met with the family and we did a consultation with talking to him, the poor lady lived there 7 years, drained her long-term care insurance, and now doesn't have any money to go anywhere. And she's not on Medicaid. And now what does she do? So that's what we want to prevent. We want to prevent those cases that the hospital is trying to get you out. So they're going to put you in respite somewhere and not really knowing the financial picture. But if you have $40,000 to your name, you go into respite and you spend that money down, they're not going to keep you anymore. We see that all the time. So we want to kind of be ahead of the game to know and educate yourself, what's out there, how does it work, and what are the red flags to really keep an eye open for.
My mom was in Bethany. Do you know Bethany down in Horseheads, New York?
I don't know. I apologize. Is
They-
that a nursing
She
home? Or?
ran into that situation. She ran out of money, and we were able to apply for Medicaid for her and get it. So she was able to move on to a level of care where she could use her Medicaid.
Right. And now what's happening now because of COVID and the lack of staff and wings of nursing homes closing down, and the level of care maybe isn't as how it was 2-3 years ago. You just have to be very careful because assets talk now. Before they did before, and now even more so. There's no waiting lists anymore. It's a waiting pool. And in that pool, there's 40 applicants. And in those 40 applicants, there's a financial picture. And they're going to see how old are you and how does your financial picture look? And I hate to be the one to say that, but that's
Your
how
money rises to the top.
Yeah. Yes. And that's what's sad. So I have a lady now that she has about $110,000, $130,000. She's in rehab in a nursing home, and the daughter is so eager to get her stronger to get out of the nursing home. And she's actually at a halfway decent nursing home right now, for where she is. And I get that the daughter wants to go into an assisted living, but if she goes into assisted living or enhanced care and spends $7,000 a month or $6,000 a month, those assets are going to drain. And when it gets to zero, where is she going to go? So those are things that we consult with families about to say, what are the options? And should we stay at this nursing home when she gets better in rehab while she's already halfway decent place? Or do we move her into a lower level of care? But then when she does need a nursing home, then what happens? You know, so we don't have that crystal ball. We just don't know what that next future is going to be, those next steps, but we just want to try to be ahead a little bit if we could. So yeah, so that enhanced care, they do not take Medicaid. Some, a very, very, very few assisted livings might say they might take Medicaid when you drain assets. Be very careful. They want to see 1.5 to 2 years of private pay in their assisted living. And if you qualify, they'll take you. But when you keep draining and 2 years comes and your money's gone, and they say, yes, we could take you on Medicaid, that's great. Or what if they say, we would love to take you on Medicaid, but we don't have any more Medicaid beds? We see that happen too. So you have to be very careful. Just because they say, and they're not going to ever say, yes, we're going to take you on Medicaid as soon as you run on money. They'll never say that. They'll just say, it's a case by case. We'll have to see. Sometimes it doesn't happen.
It was different 20 years ago when it happened to my
Yeah.
mom, you know.
Oh yeah. And it's going to keep changing. Definitely.
I have a question. Your care from your organization, is it covered by any insurances or long-term care or anything like that?
Sometimes long-term care insurance. Each policy is different. Seniors choice care management, we're nurses, we're RNs or LPNs. Sometimes through the long-term care insurance, we get it covered because we are registered and licensed through New York State, but we're not a licensed home care agency. So that's where it is case by case. Not covered by Medicaid, we're not covered by Medicare, not just our business, but any care management companies out there, same thing. The insurance companies just say we have our own care managers, but it's totally different. Definitely not the same. So yeah, it's private pay, home care aides, home care companions, all private pay. Medicaid very, very rarely, or Medicare, I should say, very rarely accepts Medicare as well. So looking at long-term care policies, sometimes we consult with families just about that and how to get it up and rolling and who to hire and who won't be approved and things like that. So
You know, rehab facilities are often covered by Medicare for a defined limit of time.
yeah, so the good question. So rehab with Medicare, if you're in the hospital with an admitting diagnosis and you're in the hospital with admitting diagnosis for 3 days or more, 3 overnights or more. So if mom just fell and there's no admitting diagnosis, and the emergency room is backed up and she sits in her gurney for 5 days in the hallway, more than likely rehab may not be paid for because there's no admitting diagnosis and she wasn't admitted as a patient, she was admitted as an observation patient. So with our patients or families that reach out to us and the patients in the emergency room, that's exactly what we want to know. Can we admit them? Can you find a diagnosis to admit them? And can we admit them as an inpatient and not observation? And those are all things that we talk to the doctors and the nurses about. If that happens and they meet that, and 5-6 days later, now, of course, they have deconditioned and they're declining a little bit by laying in bed for 6 days, then we help and assist the families getting out of the hospital into rehab. And a lot of times people aren't even sure, how do you navigate through that? And that's where, yes, the social workers are going to give you a list and they're going to say, give me 5 choices, give me 10 choices. But we're going to say, let's avoid these. Let's concentrate here, and we're going to call those places because you're going to be number 77 fax on the machine there waiting for an admission, and you may get overlooked. So we put those calls in, and we know all the admissions people in the nursing home. So we call them directly and let them look at our people first.
If I could
So-
just add something at this point, that the common ruse in the emergency room is to admit someone to observation without telling the patients or the patient's families that this is different than being admitted to the hospital.
Right.
And I think anyone who is in an emergency room contemplating admission needs to raise that issue. Is this observation or is this admission?
Absolutely. It gives me goosebumps thinking about it because it's really, really, really sad when you find out 5, 7, 10 days, even 10 days later, that they've been on observation and in a room. So you think, okay, they're up on the 5th floor. They have this nice room. It could be observation, and it's just a big waste of time sitting there. So yes,
Waste of
exactly. Sorry. Okay. I thought Sandra had a question. Yeah, so that, yes, absolutely. Definitely check. Am I observation or are you admitting me as an inpatient? For sure. Yeah. So this is what another
Can I add
red.
something? Sorry,
Yes.
can I
No,
add
no.
something? I ran into this problem with my father. This was 8 years ago. He was in the hospital and they would not, and my sisters and I are healthcare professionals, and we wanted to know if he was being admitted or under observation, and they would not give us an answer. We finally had to go to the CEO,
So,
Oh my God.
whom one of my sisters had a previous relationship with, to get him admitted as an inpatient.
Wow.
So
Wow.
it
Yeah.
helps. You've got to advocate for yourself.
Absolutely. And some people, you could advocate for yourself if you know what to advocate for.
Right.
Right.
well,
So,
during the first 23 hours we had an event with her father, they were saying he's under observation. But after that, they weren't saying whether he'd been admitted or whether he was continuing on observation. And that's when we had to get into action on it.
right. And it's the insurance companies that are really trying to hold back the hospitals from admitting. They're pushing people out. I just got a call right before I jumped on from an independent living facility attached to a nursing home. And they said, you need to hurry up and do a PRI on one of our residents. He was at the hospital and they discharged him home, and he is really, really unsafe and we cannot keep him here. So they're just really pushing, and we see it all the time, probably more so now ever than before, than 3 years ago, that they're just really trying to discharge patients. We get calls all the time from families and said, how did my mother get home? She has dementia and she's sitting in her family room by herself, and the hospitals just are trying to get people out.
Well,
So
one
we
of
have
the
to.
problems is the patient pool is growing.
Mhm. Yep,
And
absolutely.
the situation is not going to get better.
Yeah, and that's where advocacy, learning, self-advocating, but you just know just so much, right? So same thing with you're in the hospital and you need rehab, and the social worker says, give me some options of rehab places. If you're just not quite sure, having a care manager is so important to guide you through that. They look at medically, is this patient really going to progress well with therapy? But then they also look at the financial piece too. It's so important to put on that financial worksheet. Believe me, it was scary. I did it with my mother. Why isn't she being approved for rehab? My dad didn't want to show all her assets. He was worried about that. Do you show the assets? Do you not show the assets? Where, you want to protect assets. I get it, but that's what's going to get her or him into that nursing home for rehab. We get calls, we work with elder law attorneys constantly, and they're calling saying, get my client out of that place. How did he end up there? And we go back to the hospital and we go back to what they filled out in the hospital and all that. And then we're able to do a lateral move and get them out of that rehab and go somewhere else. So, yeah.
I have a question. Is there a book that covers all the terminology, like senior care, living for dummies?
No, you should write one. I should write one. No, not that I know of, but that's actually a great question. And not that I'm aware of. I could do like a little Google search on that. I mean, I know the rules and laws and cliff notes trying to educate yourself. They change constantly. So what might be said today might be a little bit different as far as that observation and things like that. But I'm not aware of that type of a resource.
Isn't it also true, though, that it varies from state to state?
Right. Yep. It does vary from state
So
to
you
state.
need to, if you're in New York, that's one question. If you're in Maine, it's quite something else, or in Maryland.
Yeah, I mean, that's a good question. I'm not sure, if I think they're all very similar though.
Well, if it's a
'cause
federal program, maybe, but in terms of maybe licensure for enhanced care.
Oh, yes, yes. And that's where, like, we have some patients that are from Rochester that travel to Florida, or, they go to
Right.
Hawaii to visit a family member, and then something happens, and, we're trying to work with the medical team down there. And so definitely questions you have to ask. It definitely could be different.
Mhm.
Yeah. We relocate patients from closer to family, either out of New York into another state. And when we have to be careful, this happened a couple months ago, a guy from California came over to New York, and the living facility, we weren't involved. We got involved when there was a crisis, but he moved from like an assisted living to an independent living. So when he got off the plane and he went there, and he didn't have his oxygen, he didn't have his nurse, and he didn't have his aide,
Ooh.
the independent living said, the salesperson said to him and the family, yep, we could get you all that, and we have those people on board. But little did they know, you have to hire them separately. They're really not part of the system. And unfortunately, the guy passed away. He passed away because he was so ill by the time he transferred over, and they didn't have the care in place. Very, very, very sad. So we have to be careful when we relocate patients. We want to make sure that where they're going is exactly what they need. The memory care assisted living, that's just like assisted living, but it's a secured unit. Patients that wander, patients that have dementia that might need more of a smaller setting, that needs help with eating, more prompting because of dementia. But it's just the locked unit that's different, and it's a smaller unit than an assisted living. And they too don't take Medicaid, so you have to be careful. You don't want to place someone there and run out of money. Nursing homes, the next level is a skilled nursing, and skilled nursing is the highest level you could go. Takes Medicaid, Medicare, if going into rehab those first few days, and we could talk about that a little bit later on in the presentation about what they cover. So
Could you,
Mhm.
could you write out a list of terms that could be used in a Google search to put together a basic manual?
And the manual would be about, what would the manual be? Like, what was your thought? Like a manual for living options, or a manual for rehab, or anything in particular you're thinking of?
All of the above.
I think he wants to look at the progression we've been talking about.
How about a glossary?
I know. I'm just writing notes here so I could kind of look into that too.
I think that that could be a useful resource and a way to put together. Somebody like you could probably do that, and as a wiki book.
I know. I think that's a great idea. No, I'll take a look at that. What families do sometimes, and this probably isn't helping you right now with the glossary or the way progression is. Sometimes families meet with a care manager just for a one-time consult. Whatever the situation you're in currently, whatever questions you're just not sure of, whatever thoughts are on your mind now because you kind of start to foresee things unfolding, the consultation is going to answer all those questions. So even though, yes, we don't have that book, we don't have that glossary, I don't want you or anyone else to feel lost. I don't want you to feel like, geez, now what do we do? Where do we go? Please let me know. We could set up a consult, even if it's over the phone and we do it, if it's not meeting at your home, whatever is good for you and easy for you guys. Because we want to answer those questions right away, and we don't want that crisis to hit. We want to be prepared ahead of time. So please keep that in mind. I know it's not helping with what you're saying, but that's probably the other avenue to go.
Are there programs in community colleges that people could enroll in to get this kind of to become
Like an elder care program type
Yeah.
thing?
Or other resources.
or other resources?
No, not really. No, there isn't. Sometimes, no, not really. I mean, sometimes some churches might have like a caregiving, and I don't want to say caregiver support group, but kind of like a caregiver group that they have speakers coming in, kind of like the Parkinson's societies as well, that they have different speakers coming in, but elder care, that actually would be a good idea at some point to maybe get something, because the elder care, because you could touch on different topics. The thing is, you there might be a topic of home care, and then there might be a topic of navigating when you're in the hospital and things like that. So the only thing I could think of again is that consult that could help you, but to have that turnkey of everything Bible at your fingertips, I don't think so.
I might mention the Office of the Aging here. They might be able to provide some information.
Yeah, the Office of the Aging, we get referrals to. What's happening with the Office of the Aging, they're going to send you lots of paperwork. They're going to send you lots of emails, and then you have to sift through everything to see what's important. So if someone calls the Office of the Aging, New York Connects, Lifespan, Elder Source, they're going to give you lots of information, which is great, but then you have to figure out, okay, now which one is good for me. So for an example, we get referrals and they send them all that information, and we meet with the family, and then we might say, okay, well, this right now doesn't pertain to you. This is a really great resource. So we kind of thin the pile down a little bit. It is a good resource. It's just not as specific sometimes. So just be careful with that too, but they do help.
So can I ask a question here? My husband and I are living in our home, and we put in a stair lift, we have grab bars. I help him with the showering and that, dressing and that sort of thing. We're fine for now, but looking ahead, how long are we going to be fine in our home? So would your organization be able to help someone in our situation with, these are your choices for continuing care. And these are the places that we might recommend. That's what we're grappling with now. We don't know how long we're going to be able to stay here. We love our home, and we think we've done a lot of things to adapt our home to my husband's mobility issues. but we're not going to be able to stay here forever. So maybe when do you start thinking about what that next step is going to be, and where do you go to get information? I mean, does your organization help with decisions like that?
Yes, yeah. So that would be the consultation. So we could, knowing that, if you call us and we schedule something, we could specifically talk about that. You know,
Okay.
if you stayed at home, how would that home care picture look? If you moved somewhere, what are the options and how much that would cost? Are there any red flags for either one? And, you know, what are the resources out there? So yes, that's exactly what we could help with.
Good to know. Thank you.
Plus also, I think it's important to be planning for an acute event. You may be getting along okay, but all of a sudden there's a fall and a broken bone,
Or a
and
stroke or
things have changed dramatically. So it's best to be able to start planning ahead.
Right.
And-
You can't wait till the last minute when
That's right.
you have to make a decision.
We have a
And-
concern
and-
sometimes that we'd like to know what a early onset of rigor mortis.
We need to be careful too, that we remember that it could be the caregiver who falls and hurts, or the caregiver who has an acute medical issue and not the person we've been caring for.
Yeah, we just went through that too. I fell and fractured my shoulder.
Oh
Mhm.
my
I haven't been
goodness.
able to drive for 6 or
Yeah.
7 weeks. So, yeah.
Yes, Pat. And that's huge, because we see that a lot. And I think we see that we've been seeing it more the last 2 years than ever. And it's because people are not wanting caregivers to come in because of COVID. They're not wanting to go to the hospital for help. So they're more ill being at home. The caregivers are getting burnt out. They're getting hurt themselves. They're getting heart attacks. They get in a car accident, things like that. So yeah, I mean, it's always nice to have that backup, because what if something happens to that caretaker? We have a program, and it's actually kind of neat. It's a maintenance program that we just touch base with our families or our patients once a month on the phone. It's for our patients that are pretty independent for the most part in the community, doing well. But then there's that extra little put your care manager in your pocket kind of thing, just in case there's a question, just in case there's a concern. There's that resource, there's that person to reach out to if the caregiver ends up in the hospital. I had one of our residents or patients, the husband actually called and said, I'm on my way to Highland. I'm in the in the ambulance right now. Sue is at home and she has dementia and she can't be home by herself. So that's how we're going to able to jump in and help with with that.
I should just throw in how I met Laurie was that in 2014, I was diagnosed with non-Hodgkin's lymphoma. John had Parkinson's. And so it occurred to me that I might die first, because it's a pretty serious opportunity for me. So that was how we found Laurie, through an elder law attorney.
Yes.
And so
Yeah.
that,
That's what happened to us too. And so now when we're looking for residences, although sure it is important to find out about extended care, it's also important to find out about respite care, and
Yep.
something that can really target both members of the household.
absolutely.
Because I'd like to have both bases covered, just in case I should be the one that has difficulty.
That's
Right.
right.
And that's where,
But I'm cured, by the way. They dismissed me.
oh, yay, good. Yeah. Good. Happy to hear that.
Reason for a party.
Absolutely.
Parties are good.
I have a question. I'm Elaine, and we currently live in Cortland, and there's a possibility that we'll be moving to the Pittsford, Rochester area at time in the near or maybe a little bit longer time. And what area do you cover? I mean, is your primary focus in the Canandaigua, Rochester area? How far is your outreach?
The majority of our services are in Monroe and Ontario County, a little bit in Wayne. a little the outskirts. Now we have people, so one of my nurse care managers had a lady in Wayne County and her family moved her, or we helped move her closer to them in New Jersey. And they actually don't even want us to close out. They want us to continue to do telephonic contact, even in a different state with the new living facility that she's at, because we want to make sure the transition goes nicely. Even though visually we can't see her, we can't just pop in and see her. We know the lingo, we know what to ask and talk about. So yeah, so being creative is what we have to do these days. And I never knew how creative I was until COVID hit, and how we had to do things virtually and telephonically. And it was just crazy. I learned a lot. So yes, so I would say the majority, Ontario, Wayne, Monroe County. But if your, family members live out of state, we could even, to a certain degree, even help with that.
Well, our primary family member lives in Monroe County in Pittsford. And so if we're heading anywhere, we're heading in that direction, not away
Oh
from.
yeah, that's my stomping ground. So nope, we all know it well, myself and my staff. So
Great.
no worries there.
And
Yeah.
when you post the information about your organization on our website, will all the contact information be there, et cetera, and sort of the range of what you do?
Yes, yep. And my website's great. So it's very specific of different services, tells a little bit about the bios of the caregiver or the care managers. So, yep, it will have all that information.
Great. Thank you very much.
You're welcome. You're welcome. On the, so the different types of services, we talked about that patient kind of lingo that you might want to remember: patient review instrument, the PRI. So if you go to your doctor and he says, go get a PRI or have a PRI done, you'll know, oh, Laurie mentioned it's a patient review instrument. It's an assessment to see what level of care a patient needs. It's good. You need it for nursing home placement. You need it for nursing home respite. And it does expire. So it expires in 3 months. Not a lot of people know that. So you're getting ready to move to a nursing home or respite, and all of a sudden they say, nope, you can't come here because it expired. That's not a good idea to do that. So make sure it doesn't expire. So know that, the PRI assessment.
And by 3 months, you mean 90 days. Because it's not defined by the calendar.
Right, yes, give or take a few more days, yes. The mini mental exam, I don't know if some people like to get a baseline when they start to, if they see a geriatric cognitive specialist, or sometimes they want to get a baseline examination. It's called a mini mental exam. Mini mental exams we also do. Your doctor definitely is going to do it more thorough. They do a test and another test and a different test. So they're going to do it really, but a lot of times families just want a quick snapshot. Where's that person on the spectrum of cognitive decline? Have a baseline. So that mini mental exam, people find very informative as well.
Spell Patagonia backwards.
And then, so the mini mental, we talked about that. And again, this is going to be on the website. I'll make sure I email that to you guys. Other services, we talk about medication management, home care coordination. So if you're just not sure, what kind of resources are out there, how much does it cost? How does it would look if we hired people to come in? Home health aides used to be, I want to say cheap. They used to be cheap before. Now they're expensive. They used to be anywhere between $24 to $28 an hour. Now they're anywhere from $30 to $42 an hour. So it's not cheap to get caregivers 24/7 around the clock anymore. It was never cheap, but now it's really expensive. It's actually more money than a nursing home. So it's definitely a lot. So we help you with all that planning. There's these really cool medication dispensers, and they're on timers. So if there's a patient that likes to take their medications soon and kind of get it confused, and you can't just keep a timer on your iPhone to go off and remind you. And we have patients that, the hospital says, no, you can't go home with your medication because you have issues with your dementia and you're going to swallow all your pills. We get them on these boxes, and you time them and you fill it and you set them up on timers. And I'm sure, Mike, being a pharmacist, you probably are aware of those boxes.
Yeah, you can actually get those if you have like a family caregiver and can set it up.
Absolutely.
You can get those independently, yes.
Yep. Yeah, we don't have them. They're all online. There's a ton of different ones. Some are easier to manage than others. Some units are huge and some are small. So, yep, your family member could set them. Some you could set, and the reminder might not be a buzzer, but it would be a family member's voice. So that's kind of neat as well.
And they have units that will not unlock until it's time. There's all levels of security and care available. Didn't used to be that way. There used to be one or two choices.
Right. Yeah.
It's expanded now.
Yeah.
It'd be nice if a little hand came out and put it right in your mouth.
Wouldn't that be nice? All these Shark Tank inventions we're thinking of today. Yeah, so we talked about the hospital to rehab as far as inpatient versus observation. We have patients now that are in rehab that we kind of just keep our thumb on the pulse, watch them in rehab, see how they're progressing. Because what people don't know until you're in it, and then you learn, Medicare with coverage with rehab, the first 21 days is covered in full. 21 days to 100 is a copay. So people, when they go to rehab, think, oh, I have first 21 days. Well, at day 14, all of a sudden they're getting a cut letter from Medicare, from the nursing home, saying your loved one is now being private pay at $650 a day, and you have 3 days to a 3-day notice. You could stay there and pay the $650 a day, or you could go home. So a lot of people don't know that if even just because you get 100 days, just because you get 21 days doesn't mean they're going to give it to you. If you're progressing, if you're not plateauing, if you are ill and you're not able to really participate in rehab 50 minutes in the morning, 50 minutes in the evening, you will get cut. And they give you a notice at 3 days, and that's it.
Been there.
It's terrible. So what we have to be careful. So when our patients are in rehab, we always tell them, try your hardest, be motivated, work on it. We tell the caretaker, caregiver, the son, the daughter, motivate your mom and dad, because if they're really not pushing, they're going to cut that person. I would go to the rehab and say, Sally, they're going to cut you, just please. And sure enough, all of a sudden the therapist calls me and says, I don't know what you did, but she's progressing. So she's, keep it going as long as possible. This is the key to get you stronger. And then once you start to plateau and the therapist documents everything, Medicare will flag it, and then you'll start to get that discontinue notice. So you got to keep it going.
That's the same with outpatient physical therapy. You have to show a certain percentage of improvement every month, or they'll cut you off.
Yeah. Yeah, absolutely. What else? Another little interesting, like I mentioned before, some of our patients that either travel and end up in a crisis down in Florida, or even not so much, but we do the relocation. So if a patient is in a nursing home, just say in Florida, and wants to be relocated up here, we do help families, because you have to get a PRI. All those patients in different states,
Right.
wherever they are. I got one from Australia the other day. They're coming into New York to a nursing home, and we have to do that assessment to get their body into New York State. So keep that in mind. We get calls all over the country for that. What else? You guys, let's see. We work closely with elder law attorneys, financial advisors. And it's because we need to make sure if we're going to fill out applications or help the family fill out applications from the hospital going into rehab or home going into nursing homes, we want to make sure, because certain nursing homes, certain places, senior communities want to see liquid assets and not money that's tied up. I had a guy, he had $500,000 in an IRA. He had no liquid assets. The nursing home wouldn't take them. And it's because the money is tied up in that. So those are things that we help with negotiating with nursing homes. We, talk to them about it. Because if you just send in a piece of paper with what it's on there, there's no story behind it. There's no one to advocate other than that paper. And it doesn't always go that great. So we need to make sure that we follow up with a phone call on those. I think, without making your head spin more, I think that is what I have in my presentation. But again, if something else, if you'd like to have any other questions, please feel free. We have some more time.
I have I have a quick question. What is the backlog in your organization taking on new people to consult?
I'm sorry, so to do consultations?
Yes.
Yes.
I would guess a consultation would be the way to start.
Yes, because what I always say is, in the consultation is a $350 consult. I would say to start with that, because you may not even need our services. You might just implement our recommendations. So we have a gentleman now that we did a consultation, and he is just implementing what we're recommending. Or some people just kind of go on a lower maintenance program and have us kind of in that background just in case. So with those, the consults, we usually book a week or so out. We've been doing a lot of consults with families, Zoom or over the phone. And then that way we could get a lot of different family members in on the call as well. So those lately have been working out very well. So I would say about a week.
Great. And that is all on your website. I mean, on what you're sharing with us.
Yes.
Great.
Yep.
Thank you very much. This has been extremely useful.
Okay,
yes.
I'm here. You mentioned the $350 for the consult. Do you have somewhere a published schedule of what your fees are for your various services?
There is not anything on the website, but it's pretty straightforward. So we bill for the consultation. The PRI is a $250 assessment. And again, it's good for 90 days. How else that we bill. So just say after the consult, you'll say, you know what, I really want to get a care manager involved just in case and to help me guide me through everything. Our consulting rate is $150 an hour, and we work off a retainer. So the retainer is $1,000. And at the end of every month, you'll get an email or in the regular mail, a itemized invoice, and you'll see all the itemizations coming off of, calls, emails, visits off that retainer. You could terminate services at any point. So if you start to get to the point that, okay, I actually feel comfortable, I know what I'm doing now, we could terminate services at any point. You get the remainder of the retainer back. I have to say, I've been doing this for 13, 14, 15 years, and we have people that are just ones that I just opened before are passing now. So they stay on. I think it's just that comfort level knowing.
And how much of this is covered by long-term care insurance or Medicare or Medicaid? Or
yeah, so the long-term care insurance depends on your policy. So you really have to, so the lingo for long-term care policy, if you call there and say, do you cover for a service coordinator or a care manager? and see what they say. Sometimes it's $150, sometimes it's $600. So it does vary. Medicare, Medicaid does not pay us at all.
Once a month phone call service.
The maintenance program. Yeah. So the maintenance program is and I don't know what county are you in?
We're in Ontario County.
Okay. Yep. So the maintenance program is a year-long program. It's a once a month phone call. And in that 6-month range, that 6-month time is a home visit. So what we normally do is we have to do our opening consult, and that's the $350. If families want to go on to that maintenance program, it's a $1,200 year-long program. And then there's that 6-month mark. What's nice about that is, if there was a crisis, if there was a concern, if you're on month 4 and you're thinking, geez, things are changing pretty quickly now, let me have another visit just to make sure. Then we could kind of just bill our time out, and you don't have to just jump into full care management. So.
Okay, thank you.
You're welcome.
You had mentioned about sending us some contact information.
For our services or
Yes.
Yes. Should I email that to you, Stuart? And then you could distribute it?
Yeah, I'll
Okay.
make sure it's on the website, or we can get that out to all our members. Yeah.
Okay, Stu, I'll plan on you sending me things, okay.
Could I just ask, when will the program be presented online through our website? Because I think our kids would really benefit from hearing this.
Oh my goodness, yes. The children are amazing. And I have to say, a lot of times it's the kids that are reaching out to us saying, oh my goodness, what are we doing? And please help us. So yeah, I love when the family is involved for sure. Yeah, so I have the presentation. I think Alexis also has that. And Alexis, I don't know if you want to email that to Stu or I could, whatever is easier.
Yeah. You folks can work it out, but it'll be out there as soon as we
It'll
can
be
get
out
it.
there.
Yeah.
Great.
Yeah.
And I would just toss in, being a healthcare provider, the whole situation is so confusing that you really do need to get an expert.
Yeah, absolutely.
Yeah.
I know, it's so confusing, and it's just hard to find the help anymore. And
it changes minute to minute.
Absolutely, you're right.
Yeah.
I have a question. What happens if you have, like, I don't have a caregiver, I'm by myself, and I have to have an operation done, of which I'm going to be at least a month, probably 2, that I need help because I'm having a shoulder done. Do you work with that at all?
Yeah, so I'm wondering, so you'll have your shoulder, is it like a rotator cuff or a replacement?
Well, it's a replacement of it.
A replacement, yeah. And I wonder if they're going to recommend rehab, like an inpatient rehab somewhere. Have they said that to you?
No, they only said that it was overnight in the hospital.
Yeah, and that's where you have to say, I don't have the support. So either one, so you either have to hire aides to come in to help you, or you may have to try to do a respite somewhere.
Makes more sense.
Right. And my worry is if you try to get aides in there, what if they don't show and you don't have a support backup?
Yeah.
They should probably provide a consult with the social worker in the hospital if she's going to be overnight. To get her possibly aides and home therapy.
Yeah. So what happens so just say you have the surgery and the next day, you stay overnight, and the next day they're going to say, okay, you're ready to go home. And you want to really make it known ahead of time that I live alone. I don't have a caretaker. Right. And so they know ahead, don't push me out because no one's home. And then, the problem is when the hospital says you're ready to go And it's going to take a while to get those aids. If the social worker in the hospital refers you out, it's going to take a while to get any help at all coming in. So sometimes we may want, or you may want to open to maybe some type aid service, just in case we could get them up and running ahead of time, to jump in quickly, because it does take a while. But it all
Where do you
depends
look
on
for that?
I'm sorry.
Where would I be looking for that?
So the social workers should have a list of home care agencies that they could refer to. Are you also in Ontario County?
Yeah, but I'm out in Honey.
Okay.
Where will you
know.
surgery, where will you have your surgery?
Gotta be Clifton Springs.
Okay, so there should be a social worker associated with the doctor who's doing that, the practice that's doing that. And that's
Okay.
the social worker that Laurie's talking about, that you should be talking to that person now.
Right.
Okay.
Right. So the doctor's office has that social worker. Talk to that person now. And then when you're in the hospital having the surgery, it will be a hospital social worker. And then you have to talk to that social worker and let them know what's happening.
Yeah.
But there's not a lot of resources in that Clifton Springs area, in that Honeoye area. It's just,
A
it's
lot of
hard.
people. Yeah.
So that's where, Clifton, if you have the surgery in Clifton Springs, maybe they might want to admit you into that rehab right there for, 7 days or a short period of time. I know I had a lady with a knee replacement in a very, very similar situation. And it took some time, but we were able to keep her at the hospital and let her go into rehab somewhere. But the insurances will try to put the kibosh to that. So just the more people you tell before your surgery, like the social worker, the better.
Okay.
Yeah. Great.
We have been
Uh-huh.
applying to our long-term care group for several months now. And my son has been doing this, and he has had one no after another. Is there a secret way to get into your long-term care you've paid for years?
I know, it's so terrible. Yes. So really what you have to do is make yourself look a little bit. So even though you want to keep your independence and you want to stay strong and you want people to know that, you could do this, you really do need to let them know, yep, I need help with showering, I need help with dressing. So when they ask you all these questions, you really need to, don't sound as independent, I guess.
All right. Yes, I understand.
Yeah. That's the only way it's going to open. I had a 95-year-old guy, and a lot of times, we try to sit in on those nurse assessments because, of course, like what she was saying, that they deny them. And I had a 95-year-old guy, he got declined 5 times. And I said, Joe, you can't. He goes, yeah, but I could do all that. I'm like, you really can't. You're unsafe. You try to do that, but you really can't. So finally it opened. He got it eventually. But
And you also need to let people know early, because I think the waiting period before the payments could begin is like 90 days with most, and sometimes even more.
90 or 100 days.
Yep.
right,
Yeah,
that elimination period, right?
Waiting period, yeah.
Yeah. So you need to be
Yes.
prepared up front to be paying for 90 or 100 days of whatever care
Right.
before
Yes.
they can pay well, they pay not everything necessarily. It depends on the rate for the nursing home or wherever you are. If the nursing home charges less than what your policy will cover, they cover everything or equal. But if the nursing home charges more, then you will be billed the difference.
Right.
Correct.
I see.
Yeah.
So I have one question. Can you once again tell me the full name of your company, that I could look up your website?
Oh, sure, absolutely. So if you Google Seniors Choice Care Management.
Okay.
So Seniors Choice Care Management,
Okay.
there's a telephone number on there. There's an email address. I mean, I could give you my number if you want. It's 585-787-0009. And if you want, I could give you my email address.
I think I hear your phone ringing already.
Oh. Uh-oh. Gotta keep my roller skates on. My email is L as in Laurie, and then my last name is Miraglia. It's Miraglia and it's seniors, SENIORS. So seniorschoicecare.com. It's a mouthful.
Okay.
Yeah. I mean, it's just, you know, care management, it's awesome. I honestly wish when my mom was ill, when my grandfather was dying, I just wish we had something like this. And more now, it gives me goosebumps thinking about it, more now than ever before, you'll see more and more care managers. It's just the difference, you know, some are social workers, some are nurses. I personally, of course, because I'm a nurse, I think nursing care managers are great because I have that medical background. And yes, social workers do too, to a certain degree. But when you need to talk to the doctor about certain things, it's always nice to have that medical background too. So.
Is your
Was your mother ever a teacher?
I'm sorry, hon?
Was your mother ever a teacher?
No, she wasn't. No, she was an office manager for a dental office.
I see.
Yeah.
Where is your office? Is it in Ontario County?
It's in Monroe County in Webster.
Okay.
Yep. But we're mobile. We move all over the place. Myself and my staff, we live out of our cars for the most part. We're always on the road.
Okay.
Yeah.
Laurie, thank you very much. This has been incredibly informative.
You're welcome.
Wonderful.
And I'm glad there are people like you out there with these skills, because as I say, it's a very confusing situation for all of us.
It is, and I'm more than happy to help you guys. Whatever you have questions, you can email me, whatever's easy for you guys. So I appreciate you guys having me to be your speaker today.
You've been
Grateful
great.
that you came.
You had some great questions, and we need to figure out an elder care group, and we need to figure out a glossary. We have lots of work to do.
Gail, will you be mailing the link